Hello everyone, Steve Zuckerman in Baton Rouge, Louisiana, here to talk a little bit about how systemic diseases may manifest with neurological problems. So, if it's at all possible to be nostalgic about giving a medical talk, this is the one for me, because some of you might remember, most of you won't, that in about 1981 or 1982 I gave this same talk when I was a second-year resident in internal medicine at Parkland Hospital in Dallas, Texas. Actually, not a hell of a lot has changed, so let's get to it. Diabetic neuropathies are very common. There's almost an epidemic of diabetes these days, likely due to lifestyle decisions. There are type 1 diabetics, of course, are the minority. They tend to come on at a much younger age due to lack of insulin production, presumably on an autoimmune versus pancreatic basis, as opposed to type 2 diabetes, which comes on later and is in fact related to being overweight, not being in shape, not doing enough exercise, and a certain degree of insulin resistance at the receptors, as opposed to the lack of production of insulin. So 8% of the overall population has diabetes, but if you're over 65, that prevalence number shoots up to 27%, and at least 50% of people who have diabetes have neurological complications. So we are going to break down the different types of neuropathies into three categories. The first being the diabetic sensorimotor polyneuropathy, or DSP, which is the most common type. The second would be different types of mononeuropathies. And finally, the involvement with the autonomic nervous system with neuropathy. So the most common form of diabetic neuropathy is this diabetic sensorimotor polyneuropathy, which afflicts about 50% of people who have diabetes. It's considered to be a length-dependent neuropathy, meaning that the longer the nerve is, the more likely it will be affected. The symptoms of this type of neuropathy are symmetrical, starting distally, usually in the feet. You'll get numbness, tingling, and possibly painful sensations. And as it progresses, it can go further up in the leg, then affect the hands, so you get the typical stocking glove distribution sensory loss, and there can be motor involvement with distal atrophy and weakness, and you can also see evidence of trophic changes and autonomic nervous system disturbances by noticing the loss of hair distally, changes in color and temperature of the skin. Other neuropathies that can occur with diabetes are considered to be mononeuropathies, meaning one individual nerve stops functioning, and that's presumably on an ischemic basis, in which the vasum nervorum doesn't supply a sufficient amount of blood, and therefore that one individual nerve stops functioning correctly. These tend to have actually a pretty decent prognosis, in that most of these recover on their own in a frame of time around 3 to 6 months. Different examples of mononeuropathies within diabetes include a diabetic third nerve palsy in the cranial nerves, in which the eye tends to look down and out and there's some ptosis, but there is pupil sparing, so that diabetic ischemic third nerve palsies don't involve the pupils, whereas posterior communicating artery aneurysms, which compress the third nerve, do involve the pupil. Another very common mononeuropathy within diabetes is a carpal tunnel syndrome, thought to represent a vulnerability of diabetic nerves to various compression. There are some other less common syndromes, one of which is the lumbosacral reticuloplexopathy, previously called the diabetic amyotrophy, which is a unilateral, extremely painful weakening and loss of sensation proximally in a leg. And another sort of mononeuropathy is a thoracoabdominal reticulopathy used to be called diabetic thoracic reticulopathy because it was in fact a nerve root, or is in fact a nerve root that gets involved, and it can be extremely painful, presents exactly like shingles. And finally, there can be involvement with the autonomic nervous system. Now, this does not usually occur in isolation. It usually happens in conjunction with a typical DSP, but it may be a very prominent symptom. And the autonomic disturbances can involve the cardiovascular system, the gastrointestinal system, and of course the genitourinary system. And there are some procedures or methods at the bedside that can be used to look for autonomic disturbances. First one of which is to look at the pupils. Secondly, you can perform an orthostatic blood pressure maneuver, looking to see whether there is a significant drop in blood pressure or a lack of reflex tachycardia in the upright position. If you want to be more sophisticated, you can do an EKG and look for the variation in the R to R interval, which there will be a significant difference when the patient is inspiring versus expiring. And if there's a lack of the RR variability, that's an indicator of autonomic disturbance. Everybody is somewhat familiar with gastrointestinal problems such as gastroparesis diabeticorum, which can be very difficult to manage, and genitourinary symptoms are very common as well. So if a patient who has diabetes starts telling you about complaints that are consistent with the symptoms and signs of a peripheral neuropathy, should further investigation be performed? Well, actually, yes, since the conclusion that a neuropathy is due to diabetes is one of exclusion. And so what do we like to exclude? Well, we look for any potential familial neuropathies. We look for toxins or medications exposures that can cause neuropathies, particularly alcohol. Always check on vitamin B12 levels, thyroid tests, and looking for monoclonal gammopathies, particularly in the IgM range, so serum protein electrophoresis and immunofixation electrophoresis, to rule out those possibilities. If those are not present, then electrophysiological studies should be performed, which we'll talk about on the next slide. Nerve conduction and velocities and EMGs should be performed to characterize their neuropathy. This slide depicts how there are muscles where there are electrodes placed over those muscles, and then the nerve gets stimulated, and timing how long it takes for that compound motor action potential to show up and dividing it by the distance will enable you to determine that nerve's velocity. In addition, there are other properties such as amplitude and duration of that compound motor action potential that can be used to interpret the study, and it will enable us to characterize whether the nerve conductions are normal, and if not, whether they indicate that the neuropathy is either of the axonal variety or a demyelinating type of neuropathy. The important thing is if there is in fact, or are in fact, features of demyelinating neuropathy, then that raises the possibility of chronic inflammatory demyelinating polyneuropathy, which is actually a treatable entity with immunomodulating techniques, whereas the diabetic neuropathies will not respond to those types of treatment. Interestingly enough, nerve conduction studies only look at the electrical behavior of the largest myelinated fibers, And since, or at least early on, diabetic neuropathies tend to involve smaller and non-myelinated fibers, there may be no reflection of any abnormal nerve conduction studies when you perform that test. Now, in regards to the treatment of the diffuse sensory motor polyneuropathy associated with diabetes, it does make sense in type 1 diabetics to attempt very strict glycemic control, because that's been shown to reduce the progression and even the prevalence of the neuropathic complication. In type 2 diabetics, on the other hand, there is no evidence that glycemic control is helpful. Also in pre-diabetics, it's not been really shown to prevent the onset of a diabetic neuropathy. There are symptomatic treatments, however, so they tend to reduce the pain. They don't, in fact, prevent the disease itself from progressing. So these fall into the categories of anticonvulsants, and in particular pregabalin and gabapentin are very commonly used and have shown to be beneficial. Other medications which have shown to be of utility include the antidepressants, amitriptyline and duloxetine. Opioids can be used with care. Topical capsaicin cream has been shown to be beneficial, and a TENS unit has been shown to be beneficial as well. I should have mentioned in the workup slide that if all of the tests are negative, even fasting blood sugar as well as the hemoglobin A1C, probably the most sensitive test to determine whether somebody is in a diabetic or even pre-diabetic state would be the 2-hour glucose tolerance test. And so if that's your suspicion, that's the extent to which you need to evaluate the patient for diabetes.